Over the next hour, we'll take an in-depth look at the prevention, diagnosis, and treatment of breast cancer. And we'll talk about the new approach called the Breast Health Project. We have a panel of experts, and they are ready to answer your questions. That's our topic. Is set to go live. We'll call a doctor right now. Hello and welcome to Call a Doctor, live from your public media studios. I'm George Thomas. Women in the United States get breast cancer more than any other type of cancer except for skin cancer. Breast cancer is second only to lung cancer as the cause of cancer deaths in women. Yet fewer than 1/3 of American women give themselves monthly breast self-examinations, even though more than 75% of all breast cancer are found by women themselves. Now here's the part you probably don't know. The American Cancer Society has stopped recommending monthly self-breast exam. The new recommendation from their Breast Health Project is what they're calling breast awareness. It's a new model of breast care based on holistic medicine using the best of Eastern and Western therapies. I'll ask our panel to explain this in detail. In addition, we'll have the most up-to-date information from our area experts on prevention, precise surgical options, and the most advanced radiation treatments such as tomotherapy. I'll also ask about the accuracy of mammograms, MRIs, ultrasound, and what's still being called a major advancement in the diagnosis of cancer, PET scans. From what you need to do for early detection, to surgery and radiation options, to reconstructive surgery, and even relationship concerns. We're going to try and cover all that for you in the next hour. Now, if you'd like to be a part of the program and have your questions or comments answered, you can simply dial the toll-free number on the bottom of your screen, and we'll get as many questions answered during the next hour. Or you can go to our website at wvia.org, and right at the top, you'll see a little button. It'll say Submit Live Show Comments. You don't need a password or a username. Just submit your question right in there, hit the enter key, and we'll be able to read your questions right off the monitor during the show. Again, so you can call in during the program or go to wvia.org and submit your questions live. Well, as I mentioned, we've assembled regional experts and they're ready to answer your questions about breast health. Let's meet them right now. Our first guest is Dr. Victor Vogel, a medical oncologist who serves as director of the Cancer Institute at Geisinger Health Systems. Also joining us is Dr. Harmar Brereton, who is board certified in internal medicine and oncology. He is the founder of the Northeast Radiation Oncology Center, and he is also professor of medicine at the Commonwealth Medical College. Our third guest is Dr. John Dawsey, a radiologist from the Community Medical Center. And our fourth guest is Abby Peck. She created an exercise program for cancer patients and survivors that is funded by the NEPA, or Northeastern Pennsylvania affiliate of the Susan G. Komen Foundation. Now, what makes Call a Doctor so very unique is the ability for you to interact live with our region's finest experts for an hour as we go beyond the trendy news soundbite and offer real information and help for you and your family. So we're going to open up those toll-free lines right now and give you the opportunity to ask your questions about breast health. Doctors, Abby, thank you very much for being here. Obviously a very, very important topic. As mentioned before the show, always the frustration with a topic like this is to get as much information out as you can. But let me start right off from what I said in the beginning. This caught me a little bit by surprise because in 2007, and Dr. Vogel, I'll go with you first. In 2007, when I did this show, I had about 10 different slides that we went through from the American Cancer Institute that talked about how women should do, the proper way for women to do self-breast examinations. Now, of course, as I mentioned, and I checked this on the American Cancer Society Foundation on their recommendations, And they are now not recommending, okay, they're not ruling it out, but they're not recommending women to do monthly breast exams. The obvious question is why?
Well, if you screen for any disease, particularly for breast cancer, what you want the screening test to do is not just find the disease, but reduce the chance that somebody will die from the disease.
Right.
Now, screening mammography does that very well. It lowers the risk of dying from breast cancer by about 30%. But what we found in studies where we looked at women doing or not doing breast self-examination is that it didn't change the risk of dying. Now, the paradox is that women who do monthly breast self-exams are actually more likely to have screening mammograms. And so we know that doing breast self-exams doesn't reduce the risk of dying, but if it means that those women who do it are more likely to have screening mammograms, and that in turn would lead to a reduced risk of dying from breast cancer, then perhaps it's a good thing to do. Part of the problem with breast self-examination is you have to be trained how to do it.
Right.
Because the untrained examiner doesn't find small early breast cancers. So if a woman is properly trained, she would probably have a better outcome, but most of the women who are doing breast self-examination aren't well trained, and so they don't find those small early lesions.
And I can understand that. In fact, even on the American Cancer website, they talk about that a lot of women, they get very upset because they don't think they're doing the examination right. But that's still, what's confusing to me is what I said in the open is 75% of the time women find the cancer, yet here you're telling them
although if more women followed the guidelines to have mammography every year, then more cancers would be found by mammography rather than by self-exam. The reason so many women find their breast cancers by a self-exam is because they've not been screened.
Mm-hmm.
And so they're finding the cancers when they're larger. Now, the advantage of breast self-examination is we like, in this whole concept of breast health, women to become familiar with their breasts, and the most important thing about a breast self-exam is finding a change,
right,
and then calling that change to the attention of a healthcare provider who can evaluate. So there are some advantages, but no proof that self-examelation reduces the chance.
Ian, I just want to make sure that I'm saying this right. They're not recommending breast self-exams, but they're not throwing it out the window either. They're saying if you're comfortable, if you've been doing that, and if you've been doing that right, then by all means feel free to continue doing that, correct?
That's right.
But just that it's just that was the rule before, and now it's not. Dr. Dawsey, let me go to you. You mentioned mammography. At what age should women start doing that?
Generally age 40.
Okay.
There have been studies that show that want people to do it later, but at this point 40 is the age to start for most people. If you have a daughter, if you have a mother who had a breast cancer at a younger age, they usually will suggest that you start about 10 years before their parent basically had the breast cancer. So if she had it at 45, you would start at age 35 instead of 40 and get yearly mammograms after that.
And most breast cancers happen in between what age range? Is it 45 to 59, I think it is? Or?
Well, it can happen at many ages,
right,
but they start to be more prevalent after age 40, and that's why they start to screen after age 40. Another reason is mammogram is less sensitive in a younger patient, but they generally don't have to worry about breast cancer before age 40 in general.
Dr. Brereton, wasn't there some controversy also about how often women should get checked?
Yes, and I think that what Dr. Vogel and Dr. Dawsey have said are very helpful guidelines for women to follow. Knowing your family history, for example, is really important. If you're going to do one thing, if you're not going to examine your own breast, for example, or you don't feel comfortable with examining your own breast and you're counting on the yearly mammogram, to know your family history and construct that is very helpful for the patient and also the patient's doctor. Because if you have a strong family history for breast cancer, for example, or a constellation of cancers that suggest you might have an early breast cancer, looking for those cancers early on is a good idea. And as Dr. Dawsey has said, that the mammogram may be less sensitive, than perhaps other ways of imaging the breast for a younger patient. And those people may benefit from different kinds of examinations than mammography.
Is that the standard mammogram? Is that the standard? I know we're going to go through the other tests that you can go through, but is that the yearly standard? That's what you want people to, or ladies to come in to get?
For me it is, but I think that ultrasounds and MRI scans, for example, can be very useful for certain patients in certain circumstances.
Okay.
Yeah,
But not screening.
but not screening.
But not screening.
And George, I wonder if we could return to that question
Sure.
about the controversy.
Yes.
So the U.S. Preventive Services Task Force at the end of 2009 said that their recommendation was that women between the ages of 40 and 49 not have mammography.
Right.
And the American Cancer Society disagreed, as did the American College of Obstetrics and Gynecology and several other professional organizations, because mammography in women 40 to 49 reduces the risk of dying from breast cancer. Now, what the task force says was, but it's only 2 women for every 1,000 women screened.
So it's not.
But the Cancer Society said, but if those 2 women are your sister or your mother
Right.
or your daughter, it's sure worth doing. And so the American Cancer Society and other organizations have said, yes, there are fewer lives saved among women screened 40 to 49 years, but we still believe it's worth doing.
I know it was very confusing in the news, because you woke up the one morning and it said, don't do it. I'm like, what, why not? And then a few months passed, and I don't think most people caught the second part about it. And so just to be clear, yearly mammograms after 40, unless there's a family history or
Yes.
some other pre-existing conditions, and then go for that. Again, you can be part of our program. Just dial that toll-free number on the bottom of your screen and we'll get your questions answered. Or you can go to our website at wvia.org and you could submit your question online very quickly, right at the top. Just type it in and we'll be able to read it right out here. Before we go to the first caller, let's go to Abby. Abby, talk about, in fact, I had the news story, of course now I can't, here it is, absolutely. And I want to thank WNEP because this came from their website. It was last year when they were talking about the race for the cure. That was the 20th year, now it's the 21st year, I think they just had it. And they quoted you, and they said, Abby Peck runs exercise sessions for over 150 breast cancer survivors in Dunmore, thanks to grant money as well, obviously from the Race for the Cure and the Susan G. Komen Foundation. First of all, you came up with this exercise program, correct?
I did, yeah.
How did all that happen?
Well, I had done some work with cancer patients and survivors in Boston who were rowers. I used to be a rowing coach, and when I moved back down here, I met Dr. Brereton. He was my dad's oncologist, and I thought about what I wanted to do, and this idea came to me, and he was generous and kind enough to allow me to try it out. And I wrote a grant to Komen, and I got the funding, and he supplies space and some additional funding for other types of cancers. And we're off and running in our 4th year, and over 200 people, and it's
So is this
great.
for, and I know you've got a great story. You want to do that story now?
George, may I embellish
You're dying
her
to do this.
answer?
Okay, please.
It's going to be. When I first met Abby, we turned out we were at the gym together, and she was on an elliptical, and I had known her. I said, "Oh, Abby, it's nice to see you. How long do you do that?" And she said, "1.5 hours." I thought, oh my goodness. Turns out Abby's not just a rowing coach, she's an Olympic athlete. She represented the United States in the 1988 Seoul Olympics.
Oh, really?
And when I discovered that and learned more about what she did for women in Boston, which was to help them recover their sense of physical health and psychological health, women that had had breast cancer, and how effective that program had been, we said, well, the Lackawanna River is no place to row your boat, but come on over and see what you can do in our office.
Neither is the Susquehanna.
Neither is the Susquehanna, by the way. But what she's been able to do with patients, one-on-one and then with groups, is to help them reestablish their sense of physical and emotional identity, which is just magnificent. And you talk to these women, and they say it's the best thing that's ever happened to them. You realize that recovery from breast cancer treatment, surgery, radiation, chemotherapy, etc., is so is so demanding, and Abby finds a way to relate to these women and help them recover in very special ways. It's wonderful to watch.
So, Abby, and again, before we get to our first phone caller, most people wouldn't associate, okay, I've just survived breast cancer, now I need to go work out.
Yeah.
So what does it do? So these people first, they walk in, for what type of exercise, what are you trying to accomplish when they're there?
Well, first of all, you're 50% less likely to get breast cancer if you're physically active, and you're 50% less likely to have recurrence if you're physically active. So exercise enhances the health of the whole body on a cellular level,
so you're boosting
on a
the immune system
systemic level. And so what I primarily do is work with people, they've often had radiation and they're kind of crispy, or they've had some surgeries that restrict their range of motion and their strength, particularly for younger women who have children. Maybe they've been told not to lift more than 5 pounds, and they have, 3 children under 8, and you can't tell a mom she can't lift her children. So we work to try to get women back having a friendly relationship with their body, because often they feel like their bodies betrayed them. We work on range of motion, strength, and working to allay fears around things like lymphedema or injuring themselves, so that they get comfortable with their bodies and they begin to, as I like to call it, they get fluent in their own body and they become more comfortable.
Is that the only exercise program in this area or in the nation, or is this a pilot program?
No, the Y actually offers a great program. The JCC offers a great program. So there are several programs. This is free due to the Komen grant and due to the stipend from Dr. Brereton's group, and which was essential to me because exercise is onerous enough. And so if you don't have to pay for it, I get a lot more people coming, and it's also one-on-one. So even though there may be a group of people there at one time, each individual has their own program that is working to deal with their own limitations.
It's very, very interesting. So let's go to our phone callers, and the first one up is Barb Connolly, and Barb is a breast cancer survivor. Barb, welcome to Call the Doctor, and go ahead with your question or comment first.
Hi. Am I supposed to share my story, or I know I met Abby before. She actually approached me down at the Race for the Cure 3 years ago. I still didn't participate in her program, but I would love to join it. And Dr. Brereton, he saw me also through my treatment. So, hi, Dr. Brereton.
Hi.
I don't know, I think I was supposed to share my story.
Yes, please, go ahead.
Okay. When I was 29, I felt a lump in my breast. It felt like a watermelon seed. And I went to my doctor's office, and unfortunately, she felt it and thought it was just due to my menstrual cycle, so she told me not to worry about it. So several months went by, and then I hit it accidentally, and it felt like a peach pit. It was a lot larger, so I had a second opinion, and we had an ultrasound, then an MRI done, and then I went to see Dr. Bannon, who suggested to have it taken out because of the size. Thankfully he did, because then 3 days later it came back positive. And with the history of breast cancer in my family, I was in fear that it would come back a second time, so I went ahead and had a double mastectomy done. But because the tumor was in there for as long as it was and it grew to the size, it was suggested that I had chemotherapy. I didn't need the radiation because Dr. Brereton said it didn't grow. It wasn't close to the bone, and I had the double mastectomy, so that pretty much took most of the tissue away. But I'm a young mom, and it's hard to, be able to be active and involved in all the activities that are out there for me, but I'm looking forward to participating in them eventually.
How long have you been cancer-free with this?
April 25th marked my 3rd year.
That's wonderful. If somebody that might be scared about calling in, or that is just recently found out that they have breast cancer diagnosed, what advice would you give them?
That they were just diagnosed breast cancer?
Yes.
To stay positive, to get involved and help others. It kind of keeps you focused on a positive and not on yourself.
Mm-hmm.
I always offer myself as help, like if they needed guidance. I always give my phone number and tell them to call me. I'd help them through anything. But you just got to stay as positive as you can. The early detection is the best, so, you try to take care of, what you need to as soon as you can.
All right, well, Barb, thank you very much for calling in and checking in with us and letting us know about your story. And keep up the good work in helping other people out there.
Thank you.
Thank you, Barb.
Yep.
Let's go on right now to talk a little about, just briefly, on who gets breast cancer, because there's a little bit of confusion on this as well. Dr. Brereton, I guess I'll start with you. Of course, women who learn through genetic testing that they have the abnormal BRCA1 or BRCA2 genes, they face very difficult decisions. They are 80 to 90% likely to get breast cancer by the age of 70. Mm-hmm. So those folks aside, as I have another question on those, research has shown that women with a family history have a higher risk for developing breast cancer. That's true whether it's on the mother's side or the father's side. So,
yes.
So who's at the greatest risk? Who should be really checking out there or going for the mammograms at age 35?
Well, it goes without saying that almost all breast cancer occurs in women, mm-hmm. but we shouldn't forget that rarely, maybe 1% of cancers do occur in men.
And by the way, when they occur in men, by the time it's detected, it's usually advanced.
It may be, and male breast cancer may be a marker for BRCA2 mm-hmm. genetic aberration, so those are interesting relationships. But there's some things that we do know, for example, that women that breastfeed, women that have earlier pregnancies, the shorter the time that a woman's breast is exposed to estrogen, the earlier the menopause, any of those things that impact estrogen exposure of the breast will tend to diminish the risk for breast cancer. So those are some epidemiologic facts that are of interest. But the caller that was just here a minute ago had a fascinating story. She was 29,
yes.
and she had a bilateral mastectomy. I think that's an interesting question for this panel, because I know that Dr. Vogel and I and many other oncologists are dealing with patients who have that as a recommendation or want it. So that question I think is relevant, and also what do we do and how do we do reconstruction are relevant topics, I think, for this.
Let's take one at a time. Now, specifically, you're talking about those that have genetic testing that have abnormal BRCA1 or BRCA2 genes. Their breast risk cancer is high as 80 or 90% by the age of 70. So with that specific, if you find one of those genes, recommendation would be a double mastectomy or not?
Well, you offer that as an option.
Just because it's
because
so
the
likely
risk is so
happen.
high.
Right.
Although interestingly, the literature shows that only half the women with known mutations elect to have prophylactic mastectomies. The other option that can be offered is these women are also at about a 40% lifetime risk of ovarian cancer. And so removing their ovaries almost completely, not totally, but 99% eliminates the risk of ovarian cancer. That also reduces their risk of developing breast cancer.
So you would do...
So we offer those women the option of, if they're finished their childbearing, we counsel them that it's perfectly acceptable to finish childbearing, but if they don't desire any more children, then talking to them about prophylactic oophorectomy, that is removing their ovaries, as a preventive strategy not only reduces their risk of ovarian cancer, but also their risk of breast cancer.
Well, how would somebody get genetic testing? I mean, it's not...
Well, so we look for a few things. So the caller, Ms. Connolly's diagnosis at age 29 would be a trigger, because the average age at diagnosis for breast cancer is 60. And 2/3 of the cases occur in women over 50. So someone that's under the age of 45 would be a reason to think about genetic counseling and testing. Any male breast cancer in the family, an ovarian cancer in the family along with breast cancer, a woman with bilateral breast cancer, both breasts being affected, or a woman herself who has had both breast and ovarian cancer, would all be reasons to seek genetic counseling and the possibility of genetic testing.
But it's also true that most women with breast cancer have no family history.
About 70 to 80% of women with breast cancer have no risk factor other than age, and the most important risk factor is age. So as we baby boomers get older,
you stole my next question. Yes.
we're going to see more breast cancer simply because it's a disease of aging women.
Let's talk about the different types of screening, and Dr. Dawsey, let's go to you. There's a lot of types of screening. First of all, for those that don't know, the yearly mammogram, women seem very, I remember when my wife had to go in for her first one. She was scared, and she came back. I said, how was it? She goes, it was nothing. There's no problem.
Most people say that, but no one believes you until it happens many times. I mean, it is scary. You're going in for a screening study to look for cancer, and that's basically the reason you're there. You'd like to come out and have a positive experience and know that there's not a cancer there.
And it's not a long procedure, right? You go in, it's a few minutes.
No, they usually 15 to 20 minutes. Right. They take two views of both breasts. They compress the breast to spread out the tissue to see it better. It was interesting, the first caller, she actually found her cancer before anyone imaged her, but she was young. And getting a mammogram in her would have not really helped. I don't think. She was still childbearing age. They did do an ultrasound, which would be appropriate. They got the MR, which probably showed that it was suspicious, and they took it out. So she wasn't of screening age, but when you get to 40, you should get the yearly mammogram. And we actually still recommend the self-exam, just so they are, just self-awareness, and they can notice changes, and then they can bring that to someone's attention.
Okay, we're already at the halfway point. We're going to come right back to you in just a second. I want to give you some websites where you can go to get some more information. There's actually 5 websites, so we're going to go through them right now. Then at the end of the program, I'm going to show you again. First one is the Northeast Radiation Oncology Center, and that is nrocdoctors.com, or just Google, like I do, Northeast Radiation Oncology Center. It's got a lot of great information. Of course, the Susan G. Komen for the Cure Foundation, wonderful website, great work that they have done as well with the pink ribbon, which years ago was, the pink ribbon now is seen everywhere on NASCAR, the great stuff they have done. And it's also a wonderful resource website, again, komen.org. Geisinger Health Systems, of course, a lot of information on treating breast cancer, just www.geisinger.org. Of course, the Community Medical Center as well, cmccare.org, where you can get information. And of course, our good friends at Allied Services, www.allied-services.org. I'd like to reintroduce our panel members that we have with us for this program. Again, if you'd like to be a part of the program, please dial the phone on the bottom, or the number on the bottom of your screen, and we'll try and get your questions answered. Our first guest is Dr. Victor Vogel, a medical oncologist who serves as director of the Cancer Institute at Geisinger Health Systems. Our second guest is Dr. Harmar Brereton, board certified in internal medicine and oncology, founder of the Northeast Radiation Oncology Center, and professor of medicine at the Commonwealth Medical College. Dr. Dawsey, a radiologist from the Community Medical Center. And Abby Peck, she created an exercise program we heard about before for cancer patients and survivors that is funded by the Northeastern Pennsylvania affiliate of the Susan G. Komen Foundation. And as I mentioned, we'll try and get as many of your questions answered as we can. And I'll show you those websites again at the end of the program. Dr. Dawsey, let's go back to you. So mammogram, that's just for screening. Now there's other ones, and please, Dr. Brereton and Dr. Vogel, chime in here. Ultrasound, when would you use ultrasound? That's not used as a...
No, that's not a first-line screening study.
Okay, so when would you use that and for what?
Well, when you come in for your mammogram, you would get some pictures, and if we see something on the mammogram, or if there's a palpable abnormality or something that the patient feels, we would want to see first if we can see that on the mammogram. If we do see something on the mammogram, then we would want to examine that a little bit further. Ultrasound is simple to do, it's painless, and we can usually have it done the same day at the same time. The ultrasound would be something to, if we see an abnormality on the mammogram, we could decide if it's either a cyst, which is more common in younger women, or if it's solid, which would be potentially more ominous because that could represent a cancer. A cyst is not a cancer. It's not pre-malignant, but a mass would be something that would need to be evaluated further.
Dr. Vogel, let me go for this next one, the MRI, magnetic resonance imaging. Is that better, or just I'm just trying to line these up. You've got...
Yeah. I don't want to get too technical.
Ultrasounds, MRI, and PET scans.
What MRI does is it's more sensitive. That is, it finds more cancers, but it's less specific, so it finds everything. It finds benign things, it finds cancer. So we largely restrict the use of MRI to very high-risk women. So the mutation carriers that you were talking about earlier, there are studies that show that if you combine mammography and MRI in those women, it actually performs a little better, probably because many of those women who we screen with genetic abnormalities are younger. And in patients with a known breast cancer diagnosis, we often use MRI to guide the surgeon and the radiologist to make sure there's no additional areas of tumor involvement in either the breast where the tumor was found or in the opposite breast. So MRI has largely a diagnostic and guiding the treatment kind of a role rather than a screening role at the present time.
Dr. Brereton, my quote from back in 2007, when I did a show on this topic, it came from breastcancer.org. Again, this is 2007, so 5 years ago. PET scans are still in the experimental phase and are one of the newest breast cancer diagnostic techniques around. Where are we at now 5 years later?
I think that once a patient has a known diagnosis of breast cancer, that a PET scan can be helpful in identifying additional areas of cancer and can set the stage for proper allocation of treatment. But they're not useful, to my knowledge anyway, and Dr. can help us with that, in diagnosing primary breast cancer. Although ironically, in getting PET scans in some patients for other reasons, we found a breast cancer unexpectedly. So it does happen.
So, and I don't want to confuse everybody, but the doctors will know which, if you suspect you have breast cancer, other than the yearly test, the mammogram, the doctors will suggest, okay, here we're going to use the MRI, the PET scan, or the ultrasound.
Yes.
One final question. We're going to go back to the phones in a second here. And by the way, keep those phone calls coming in until the top of the hour. Just dial that toll-free number at the bottom of your screen. Dr. Dawsey will have this one for you. It comes from Shamokin. The question is, there's a missing space on the mammogram. Is the missing space on the image fiber, growth of tissue, or could that be cancer, and can they distinguish that easily? I know without seeing
I'm not
the,
sure
the film
what a missing space is. I suspect she had a mammogram and they said that there was, a finding of some sort. If they didn't do anything more than the mammogram, I suspect it may just be the normal tissue that's there may have involuted, which the milk-forming duct or tissue will involute over time, and the breast can change over time, and that may be what they're talking about. I would have to see the mammogram to see exactly what she's talking about. But if they stopped it at a mammogram point and said, and they said okay, I suspect it's not anything to worry about. But certainly it's something to ask her physician to clarify, to her certainly, what this is talking about, or what they mentioned in the report, if she did get the report to read it.
Let's go back to our phones right now. Let's say hello to Kim in Lake Wallenpaupack. Kim, welcome to Call the Doctor, and go ahead with your questions, please.
I actually don't have a question. I have some just comments. I am one of the fortunate breast cancer survivors who had fortunate enough to be treated by Dr. Brereton, and who also participates in Abby Peck's program, exercise program. And I can't say enough about both of these people and how crucial they were to my recovery and survival. And I guess the other thing I would want to say is that the doctors take care of the physical part of helping cure us and eliminate the cancer from us, but there's other components there of the mind and spirit. And I just think that's an important thing to mention. Physically being active and exercising just helps everything. In fact, some of the girls that exercise at Abby's are stronger now than they were prior to getting cancer.
Excellent.
The bond that we form together is just helps our spirit, and that's really what I have to say, is just what a wonderful program it is, and really to thank both of them.
Well, Kim, thank you very much. Abby, your response?
Well, thank you, Kim. And it's true that it really is. This is the best job I've ever had, and I've had some really great jobs. But
The Olympics is pretty cool.
to see women coming in really all different capabilities, depending on what's been going on, and to have them be able to share their stories in the space with each other, provide support and a guiding light, particularly for women who are in that dark tunnel and don't see the light at the end. These women represent the light at the end because they are strong, they are positive, they're energized, they're enthusiastic, and they are reclaiming their bodies. They're able to reach for that cookie jar that's up at the the top shelf, whereas maybe when they came in they didn't have much range of motion. So as much as what I do, these people do for each other, which is really spectacular for spirit.
And if somebody wants to get in touch with you about that program, that's through where again?
Oh, they can call the offices at NROC, or I'm not going to give my cell phone on the television.
You'll get a lot of calls. Before we go to our next phone caller, by the way, keep the calls coming in, or you can go to our website at wvi.org, and you can click on there and submit your live show comments. Statistics in 2010, this comes from the American Cancer Society. Estimated 207,000 new cases of invasive breast cancers were expected to be diagnosed in women in the U.S., along with 54,000 new cases of non-invasive breast cancer. From 1999 to 2006, breast cancer incident rates in the United States decreased by about 2% per year. Dr. Brereton, I'll start with you. Are we winning the war on breast cancer? Are we chipping away at that?
I think we're getting there. I don't like the phrase winning the war. I think we're having a much better informed population. Our technologies are far more accurate, and so we're chipping away. Yeah, we're getting there.
You mentioned...
And before we get away from that, I wanted to comment on the best way to make the progress that all of us want is through clinical research. And I know that the Geisinger Cancer Institute, for example, and our organization provide all kinds of wonderful research opportunities for women to participate in. And that's the way we make the progress, by participating in national trials, clinical trials that allow us to make those small incremental steps forward.
Is there, and this comes from Patrick Leahy, back in 2000, he went to the floor, he said this: the war on breast cancer is particularly important to women of Vermont. Of course, he was representing Vermont at that time, because the state has a disproportionately high percentage of women who die from breast cancer. These alarmingly high mortality rates present throughout the Northeast and Mid-Atlantic region led to their introduction at that time for a breast cancer program. Is that true? Are we living in a breast cancer cluster in the northeastern region of the United States?
I can give you my opinion, but I'd be interested in the opinion of the other panel members and someone who's not here. The Northeast Regional Cancer Institute has a population-based registry that was established years ago and has a wonderful database that looks at this. And Sam Leshko, who's a physician and the epidemiologist who runs that program, has looked at that. There are some cancers for which we have a very high incidence in Northeast Pennsylvania. For example, colorectal cancer is a particular problem for us.
Yes.
And we happen to have the highest incidence of thyroid cancer of any place in the United States. So these are very important questions, but breast cancer doesn't fall into that area, to my knowledge. Sam would be a better person to answer that, or perhaps Dr. Vogel.
Doctors?
Well, the other thing about that, George, is people are understandably concerned about the possibility of an environmental cause of breast cancer.
Right.
But we have looked very, very carefully at many, many things in the environment, and other than the unfortunate exposure to atomic irradiation during the war, or a disaster like Chernobyl or Japan, it is just very, very difficult to identify environmental causes. So I think at least for breast cancer, we can reassure patients that it's not things in their environment that are causing breast cancer to occur. We don't know what it is. One day we probably will, but I think we can alleviate people's concerns about the food they eat or the water they drink or where they live or the air they breathe being the cause, because all the evidence suggests that there's nothing there.
Would you like to comment on that?
No, I agree with that.
Just agree with them. That's good. Let's go back to the phones right now. Joan from Dallas. Joan, thank you for waiting. Go ahead. You're up next on the program with your question.
Hi. I would like to ask the panel, especially the physicians, why there is a shortage still of some cancer medications.
I'm sorry, I didn't catch all of that.
Shortage of cancer medications.
Is there?
There's a shortage.
Okay, is there a shortage of cancer medications?
There is, particularly injectable medications, and we've encountered rotating shortages of drugs that we use to treat breast and other cancers. I'm certainly not a health economist and don't pretend to know the reason, but part of the reason is that many of these drugs are now generic, and there is very little profit incentive for the drug companies to make many of our daily use cancer drugs. And there is efforts in the Congress to correct this problem, working with the FDA. But yes, it's a real problem, and I myself have had patients who could not get access to the drugs I prescribed because of these shortages.
If, I guess the front line, or most people would think the front line of defense in treating breast cancer would be surgery.
Yes, it is, but many patients also require chemotherapy.
After that?
After that.
So where would the drugs fit in with that?
So for patients with larger tumors or patients with lymph nodes under their arm, the so-called axillary lymph nodes that are involved with tumor, many of those patients require chemotherapy. And one of those drugs, a drug called adriamycin, about a year ago was not available for a time. So this is a real concern, and we've got to address as a nation the issue of making drugs that are necessary but not necessarily profitable. Yeah. So, but apparently both the FDA and the Congress are working on that problem.
It's wonderful. Let's go back to the phones right now. Anne Marie from Dunmore. Anne, thank you for waiting. Welcome to Call the Doctor, and go ahead.
Hi. Well, I just wanted to say that I am a cancer survivor, and I take part in Abby's wonderful program. She's just so supportive and caring. I mean, the doctors do their part. They do the surgery, the chemo, the radiation. But Abby's program is so important. It's an important piece of the puzzle. You put us back together again. We're a really close-knit group. We've all dealt with the words, "you have cancer." But you know what? We come out feeling so well at the end of the experience, and it's all due to her. We get together socially. I mean, it's just a great program. We're so fortunate to have that in this area. And I want to thank Dr. Brereton and Abby for beginning the whole thing.
Well, thank you very much. Abby, I'm coming back to you then on this one. Since you've been dealing with these ladies, first of all, do you talk about the relationship that they're in? You mentioned before, a lot of times they feel like their body has failed them.
Yeah.
You know, now, of course, intimacy is going to play in that role. Do they feel, after they go through your program, or do they talk about those intimacy issues?
Yeah, I mean, there are a lot of different relationship issues. I think for some women, it's the first time the attention's ever been on them.
Right.
I think for some women, it's been a wake-up call. I'm really intrigued by the number of people, men and women, who I work with who have said that cancer has actually been a gift for them because it has helped them to readjust their priorities, really pay attention to their relationships, and they now have more positive, more healthy relationships because they're really focusing on the things that truly matter to them rather than getting stuck in all the small stuff. I think that in terms of intimacy, when you feel more comfortable in your body, which one does if one is exercising and feeling healthier and stronger, that is less awkward, because I know that for a lot of the women who've been basically mutilated through their surgeries, there's a tremendous amount of self-consciousness,
Yes.
Particularly in a society that is so hyper-conscious about looks. And I think that one of the things that not only that my program, but all the exercise programs do, and support groups, is help women feel less, I don't really know what the word is, but less alone and less deformed, I guess, if you want to say that.
Let me read this quote to you, and then I want to get your take on that, and then I want to go to the doctors to talk about reconstruction, because what is happening there is tremendous. This comes from breastcancer.org, and it quotes this: what do partners of breast cancer patients care about most? In spite of what you may imagine or fear, studies show that the answer is simply this: their loved one is alive and feeling well. The loss or alteration of a breast is almost meaningless in contrast. In fact, one person said, "I don't care what they take from you as long as I can see your face."
Yeah, I would agree. I am just so deeply touched at the care and the love and the concern that the partners of the people that I work with have, that, you know, in a society, as I said, which, you know, is so sexualized, and women's breasts are sort of their identity of femininity. These people, predominantly the husbands of women that I work with, are so tender and so caring and so concerned, and they just want the love of their life to be healthy and to spend the rest of their lives together, you know.
Let's talk about reconstruction, and I'll leave it up to her, because I'll do the story. We had a person I know that went through this, and once they heard they had breast cancer, of course, they're going through you know, the whole process. They had both breasts removed, and sitting in the doctor's office, and the doctor, you know, deadpan as can be, saying, "Okay, you know, we're going to do this, and we're going to do the reconstruction." And he said, "What size would you like to be?" And she was just kind of taken aback. So, "Well, what do you mean?" He said, "Well, you know, we're going to do the reconstruction. You're a candidate for it, on and on. You know, what size? Well, you know, would you want to, you know, be a C?" And he's not laughing, and she starts laughing. And then finally he lets on. He said, "That's what's possible now in many cases with reconstruction." So let's talk about that. There's a lot's being done in reconstruction after breast cancer, after the removal of both breasts.
Yeah, I've actually joked with some of my patients at their initiation about, you know, getting the breasts they always wanted. And so
yeah,
forth.
kind of. Yeah, how big do you want to be?
And the best part of this, George, is that there's several options now. We can use breast implants, which is synthetic material, silicone, or saline, salt water in a essentially a plastic bag, or you can use the woman's own body tissue. We can take tissue from the belly, the abdomen, or from the flank, the side, and we can move muscle and fat into the area where the breast has been removed and create breast tissue that looks very, very much like and feels very much like the original breast tissue. And the plastic surgeons can even recreate nipples and do tattooing so that those breasts look very, very natural. And I've had many, many patients over the years who've been very, very pleased with their reconstruction. So it's something that we can offer to patients who need a mastectomy for treatment reasons, but who don't want to go through the rest of their lives without breast tissue.
Are all, and coming back to what you just mentioned, because they're worried about their disfigurement, are all ladies that have both breasts removed, are they all candidates for reconstruction?
Most are, but what amazes me is that some women say, oh, I just don't want it done. But I've also seen women in their 70s who say, I'm having reconstruction. Mm-hmm. And if that's their choice, we help them to make that happen.
And you mentioned about tattooing. I had skin cancer on my back, and after about 10 years, I was tired of the scar, and the person I went to, they actually specialized in that. They specialized in tattooing, and they worked on my back, working on it. It was amazing talking to him what he could do. He said, you can't tell the difference, really. You have a comment?
I would agree with what Dr. Vogel has said. I think that the priority for women in their treatment is cure. And because women who require a mastectomy often need chemotherapy and may need radiation as well, that it's important to time the reconstruction appropriately so that it doesn't interfere with the curative treatments, which include chemotherapy and radiation.
And you want to make sure there's distance between.
Well, I think that because if a woman chooses immediate reconstruction, for example, she has the mastectomy and immediate reconstruction, and there's a complication that occurs that postpones the curative treatment of chemotherapy or radiation, that's not a good thing. So I ask my patients to consider timing the reconstruction appropriately. And if they can wait for 6 months after the treatment is over, several things happen. Some women say, you know, I've been living this last 6 months without the reconstruction. I really changed my mind. I don't want that. And it is a surgical procedure that does entail certain risks. So if she can be satisfied without it, then that's a good thing. And if she waits for the 6 months and has a good reconstruction with her curative treatment behind her, then that's a good thing. So I think counseling people to be patient and doing it in an appropriate time frame is a good thing.
Let's go back to the phones. Al, you're up next. We've got about 2 minutes left of the program. Your comment or question quickly, please.
Okay, this is Al Speakman. Had breast cancer 20 years ago. Had a modified mastectomy, radiation treatment, and took tamoxifen for 15 years. It reoccurred this year again, but under the armpit. And the problem I'm having right now is trying to get my legs back to normal. And I understand that's possibly a result of the chemo that I took this time. So is there an exercise program to get your legs back? I've never had arthritis, but I guess if I had to describe it, would be like that. They're unpredictable.
Let me throw it to the panel.
Yeah, absolutely. Give me a call. I do a lot of work with people who have not only neuropathy, but weakness, sense of heaviness in the legs, feeling like they can't really trust their legs, loss of balance. All of those things can be improved.
Yeah, several of our drugs can cause temporary damage to the nerves, but it typically comes back, and I think an exercise program like Abby's talking about would help in this and in most situations.
We have about 1 minute left. Let me give you those websites again where you can get some great information. In fact, the first one is Northeast Radiation Oncology Center, nrocdoctors.com. Also through there, you can get in touch with Abby, since she won't give out her cell phone number. The Susan G. Komen for the Cure Foundation, wonderful website and great organization. Komen.org. They have a lot of fundraisers to raise for the cure. I don't know if they have a golf tournament, but if they do, I'm getting in on that one. Geisinger Health Systems, another great website, www.geisinger.org. The Community Medical Center, which is just groundbreaking in our area, cmccare.org. And of course, our very good friends at Allied Services, alliedservices.org. I'd like to thank our panel members for joining us. Thank you, Dr. Vogel, Dr. Dawsey, Dr. Brereton, and Abby. And I want to thank you for watching us, and make sure you join us next week for another informative Call the Doctor.